Good morning. So for the third lecture for today, I'm Dr. Maria Sarah LENON, and I will give to you an overview on the microscopic examination of the urine. So we know that the urine sediment contains a variety of materials, and some of which are normal while others are abnormal. So it's important for us to learn how to identify both these normal and abnormal constituents, as recognition of such abnormal constituents is very important in the diagnosis and treatment of various renal diseases. So their presence can likewise confirm the different abnormal findings we take note of in the physical and chemical tests. So the importance of the microscopic examination of the urine sediment allows localization of the site of pathology in identifying the presence of a dysmorphic versus isomorphic erythrocytes. There is that diagnostic potential to differentiate between a medical renal disease from that of a lower urinary tract or urologic disease. This also allows us to differentiate between an infectious versus an inflammatory process. So microscopic examination of the urine sediment is said to be the least standardized and the most time-consuming part of routine urinalysis. To be able to enhance the cost-effectiveness of urinalysis, many laboratories would have developed protocols whereby microscopic examination of the urine sediment would only be performed on specimens meeting a specified criteria. This is known as your macroscopic screening or chemical sieving, where abnormalities in the physical and chemical portions of the urinalysis would play a primary role in the decision to perform a microscopic analysis. And you have different parameters including the abnormalities in urine color, the clarity, presence of blood, protein, nitrite, leukocyte esterase, and possibly glucose. So microscopic analysis is subject to several procedural variations, but mentioned here are the basic steps needed to prepare a urine sediment prior to microscopic analysis. So the urine ought to be examined at its fresh or adequately preserved state. Refrigeration can cause precipitations of crystals that can obscure other elements in the urine sediment, hence warming the specimen prior to centrifugation may be needed to dissolve these crystals. Of course, the urine ought to be optimally collected via a midstream clean catch to minimize external contamination. Now, the standard volume of urine examined should be ranging from 10 to 15 ml, average of 12 ml, and this is optimal as this allows the multiparameter reagent strips to be easily immersed in this volume, and the cap centrifuge tubes are often calibrated to this volume. Now, the speed of the centrifuge and the length of the time specimen is centrifuged should be consistent, and this is about 5 minutes at 400 relative centrifugal force. This produces an optimum amount of sediment with the least chance of damaging the elements. Now, there should be a uniform amount of urine and sediment contained in the tube after decantation, and this is about 0.5 to 1 ml in volume. So to maintain this uniform sediment concentration factor, where the urine should be aspirated off rather than poured off unless otherwise specified. Now, the volume of sediment placed on the microscope slide should also be consistent, about 20 microliters, and covered by a 22 by 22 millimeter cover slip. So allowing the specimen to flow outside of the cover slip can result in the loss of the heavier elements such as your casts. How the microscopic examinations performed should be consistent and should include observation of a minimum of 10 fields under both lower and higher power. The slide is first examined under low power to detect casts and to ascertain the general composition of the sediment. So when the elements such as casts that require identification are encountered, the setting is changed to high power. When the sediment is examined unstained, many sediment constituents have a refractive index similar to urine. Therefore, it's essential that the sediments be examined under reduced light when using bright field microscopy. So the initial focusing can be difficult when examining fluid specimen, and care must be taken to ensure that the examination is being performed in the correct plane. So often an epithelial cell will be present to provide a point of reference, and focusing on artifacts should be avoided because they are often larger than the sediment elements and can cause the microscopist to examine objects in the wrong plane. So the terminology and the methods of reporting may differ slightly among laboratories in terms of the microscopic examinations. So routinely, the casts are reported as the average number per low power field following examination of 10 fields. The cellular elements like red blood cells and WBCs are reported as the average number per 10 high power fields. Epithelial cells, crystals, and other elements, these are frequently reported in semi-quantitative terms such as rare, few, moderate, and many, or as 1+, 2+, 3+, and 4+, following the laboratory format as to the use of LPF or HPF. So laboratories must also determine their particular reference values based on the sediment concentration factor in use. So microscopic results should be correlated with the physical and chemical findings to ensure the accuracy of the report, and specimens in which the results do not correlate must be rechecked for both technical and clerical errors. So here, this table would show some of the more common correlations in the urinalysis. However, the amount of formed elements or chemicals must also be considered, including the possibility of interference with the chemical tests and the age of the specimen. Since there are many factors that can influence the appearance of urinary sediments, these include the cells and casts in varying stages of development and degeneration, distortion of the cells and crystals by the chemical content of the specimen, the presence of inclusions in cells and casts, and contamination by artifacts. Hence, identification can sometimes be very difficult. Hence, utilization of sediment examination techniques like various urinary microscopy can be utilized. So the bright field microscopy is the one that we use for routine urinalysis. However, enhanced visualization of elements, especially with those with low refractive indices, can be aided by the use of phase contrast microscopy or even polarizing microscopy to aid in identification of elements like your oval fat bodies, fatty casts, and crystals. Dark field microscopy can aid in identification of microbial elements like your Treponema pallidum, as well as the fluorescence microscopy and interference contrast microscopy. So in phase contrast microscopy, this allows enhancement of the contrast of a transparent and colorless objects by influencing the optical path of light. So it uses the fact that the light passing through a transparent part of the specimen to travel slower, and due to this is shifted compared to the uninfluenced light. So the particles tend to appear better seen against the background of phase contrast microscopy than with bright field microscopy, where certain elements tend to stand out. So in polarized microscopy, this is a technique that exploits optical properties of anisotropy, which represents difference in the physical properties like absorbance, refractive index, and densities. This will reveal detailed information about a particular structure and the composition. So for instance, here we see the lipid particles appearing as shining particles containing a black cross or the Maltese cross, which allows identification of atypically appearing lipid particles. So there are different urinary sediment special stains that help in identification of such sediments that are difficult to characterize. So we have the Sternheimer Malbin, toluidine blue, and acetic acid. They help in delineation of the structure of the nuclei and the cytoplasm. They enhance the nuclear detail of the cells that allows identification of the WBCs from the epithelial cells and the casts. There are lipid stains such as oil redo and Sudan 3 that stains the triglycerides and neutral fats orange red to be able to identify free fat droplets and lipid-containing cells in casts. Now, the gram stain we know is used to differentiate from gram-positive from gram-negative bacteria and aids in identification of bacterial casts along with WBC casts. Now, the Hansel stain is the preferred stain for eosinophilic granules that's used to identify urinary eosinophils. And the Prussian blue stain would stain structures containing iron, and they exhibit yellow-brown granules of hemosiderin in cells and casts. So here is a diagrammatic representation of the different organized elements present in urinary sediment. So we have the different types of cells, lipids, casts, and crystals, even microorganisms that are identifiable upon microscopic examination of the urinary sediment. So the arch nemesis of every laboratory personnel would be looking at artifacts, and it takes experience to be able to recognize such. And artifacts can often be confused with different cellular elements or pathologic elements like the red blood cells and the casts. Hence, artifacts can be problematic to some. So they are often appearing to be highly refractile or can occur in different microscopic planes than the true sediment constituents. So reporting artifacts is often not necessary, but avoiding them can be done by the use of clean slides and using the paper separator between slides, the prevention of contamination of the specimen by using sterile collection of containers and proper procedures for collection, and also proper specimen collection techniques by the use of clean or sterile pipettes. So here are some examples of artifacts. You have on the left is a rounded structure with concentric circles representing a pollen grain. On the right, you see highly refractile spheres with a dimpled center representing starch granules, which are coming from the cornstarch or cornstarch powder used in powdered gloves that may be used by the laboratory personnel doing the microscopic examination. They can resemble fat droplets, or they can also be confused with red blood cells. So what we can do is use polarizing microscopy and to be able to identify Maltese cross from an actual fat droplet, or a red blood cell can be differentiated from these starch granules by considering other urinalysis results like the chemical test positivity for blood protein, and also the presence of the oval fat bodies or fatty casts can differentiate these starch granules from the fat droplets. So you can see here a fecal material admixed with oil artifacts, and also a vegetable fiber somewhat resembling a waxy cast. So they may appear as plant and meat fibers or can appear as brown amorphous material in a variety of sizes and shapes. So we can see here fibers that somewhat resemble a cast. Notice the refractility of these artifactual fibers. So the fibers usually are longer and more refractile, and examination under polarized light can frequently differentiate between the fibers and the casts. So we can see here a fiber under polarized light. So differentiating fibers from casts is that fibers would often polarize, whereas casts, apart from the fatty casts, usually would not. So these are the different cellular elements that are often identified in the microscopic examination of urinary sediments. So from the blood, I can identify the different erythrocytes, leukocytes, and macrophages and their different subtypes. And of course, the epithelial cells are the different types of such would be the tubular cells, transitional cells, and even the squamous cells. So red blood cells in the urine appear as smooth, non-nucleated biconcave discs measuring approximately 7 millimeters in diameter. They must be identified using high-power objective, and our red blood cells in the urine are routinely reported as the average number seen in 10 high-power fields. So RBCs can be difficult for some to recognize. The reason for this is that the red blood cells can lack characteristic structures and variation in the size and often closely resemble other urinary sediment constituents. Like they can be confused with yeast cells, oil droplets, and even air bubbles. So in a concentrated or hyperstenuric urine, the red blood cells tend to shrink due to the loss of water and may appear crenated or irregularly shaped red cells. So red cells in the urine is a frequent finding, often seen in more than 50% of the specimens. So up to 5 red cells per high power field is generally accepted as normal. And hematuria is defined as an increase in the number of red cells in the urine. According to the American Urologic Association guidelines, more than 3 red cells per high power field on a properly collected specimen in the absence of a benign cause is indicative of hematuria, and they can be classified into a glomerular or non-glomerular type in reference to the presence of dysmorphic and isomorphic cells respectively. So the possible causes of hematuria can arise from hemorrhage along the urinary tract, inflammation, necrosis, trauma, and even neoplasms along the urinary or urogenital tract in voided specimens. So recognition of the dysmorphic erythrocytes are of clinical significance. So the dysmorphic erythrocytes appear as red cells with irregularity in the shape, variation in the size, and distorted cellular membranes with vesicle-shaped protrusions in the form of acanthocytic or crenated red cells. So presence of 20% of dysmorphic erythrocytes examined under the urinary microscopy may suggest a renal origin of the hematuria. So the clinical significance of the presence of red cells in the urine may be associated with glomerular membrane or vascular injury within the genitourinary tract, and the number of cells present may be indicative of the extent of damage or injury. And the macroscopic hematuria is associated with advanced glomerular damage or damage to the vascular integrity of the urinary tract, like in trauma, acute infection or inflammation, or coagulation disorders. Now, grossly, the macroscopic hematuria can appear to be a cloudy urine with red to brown discoloration. Now, macroscopic hematuria can be associated with an early diagnosis of glomerular disorders or even a malignancy of the urinary tract or presence of urinary calculi. Now, microscopic hematuria can also be evident in strenuous exercise, especially in the presence of cast and even menstrual contamination. So it's important that the dysmorphic red cells, the red cells, be distinguished from their common mimics like the yeast cells, air bubbles, and even oil droplets. So dysmorphic red cells are seen here on the left upper quadrant, while you have the yeast cells on the right upper quadrant. Notice the presence of budding forms that aids in distinguishing them from the red cells. You have the air bubble on the left lower quadrant. Notice the absence of formed elements in the area of focus. And on the right lower quadrant, we have a stained squamous epithelial cell adjacent to oil droplets. So the oil droplets and the air bubbles, they are highly refractile when the fine adjustment is focused up and down, and they may also appear in a different plane than the other sediment constituents. So white blood cells in the urine appear larger than the red cells. They measure an average of about 12 millimeters in diameter. And the predominant type of WBC seen in the urine are neutrophils. Neutrophils contain granules and have multilobated nuclei, and they are often identified using the high power and reported as an average number seen in 10 high power fields. So they lyse rapidly in alkaline urine and begin to lose their nuclear details. So in an unstained urine sediment, they can typically appear as round granular cells, which are about 1.5 to 2 times the diameter of red cells. So again, let's note the multilobation of the nuclei when identifiable on the WBCs, And here we see a clump of WBC that is different from the WBC cast. So up to 5 WBCs per high power field in the urine is commonly considered normal. So pyuria is the term we use in reference to an increase in the number of WBCs in the urine. And presence of WBCs in the urine is indicative of an infection or inflammation in the genitourinary system. So presence of an inflammatory process somewhere along the course of the urinary or urogenital tract can be present in non-bacterial disorders like glomerulonephritis, lupus nephritis, interstitial nephritis, and even tumors. Now, in urinary tract infection, along with a significant amount of bacteria seen on the urine sediment site preparation, can indicate the need for a bacterial culture. And these are the common causes of pyuria in association with bacterial infections in the form of pyelonephritis, cystitis, prostatitis, and even urethritis. So we see here a microphotograph of a urinary sediment showing the WBCs. These are the larger cells with granulated cytoplasm, while the rounded enucleated smaller cellular structures are representative of the red cells in the urine. So eosinophils can also be identified in the urine, but these entail the use of special stains, and the preferred eosinophil stains would be the Hansel stains, or the right special stain can also be used on a concentrated urine that can be a routine urinalysis specimen or a centrifuge urine specimen. And often than not, the eosinophils are counted in 100 to 500 cells, and a significant finding would be more than 1%. So eosinophils in the urine clinically implies drug-induced interstitial nephritis, a urinary tract infection, and it can be seen in renal transplant rejection. So mononuclear cells in the urine can likewise be identified in the form of lymphocytes, monocytes, macrophages, and histiocytes. So lymphocytes, these are the smallest of the red cells and often resemble red blood cells. Now, the monocytes, macrophages, histiocytes, on the other hand, appear larger with a vacuolated cytoplasm or presence of inclusion bodies in the cytoplasm. Now, the primary concern here is to differentiate the mononuclear cells from disintegrating neutrophils and from renal tubular epithelial cells. Now, the renal tubular epithelial cells, they would appear to be somewhat larger than the leukocytes. They're more polyhedral in shape, and they would have eccentrically located nuclei. The WBC and amoeboid motion can be difficult to distinguish from the renal tubular epithelial cell because of the irregularity in the shape. So supravital staining or the addition of acetic acid can be used to enhance the nuclear detail if necessary. So here's an example of identification of the WBCs with the use of acetic acid to be able to enhance the nuclear detail and identify the leukocytes present in this urinary sediment. So epithelial cells found in the urine is not unusual, as this may represent sloughing off of old cells that line the genitourinary system. So present in large numbers or abnormal forms, however, can be of clinical significance. So there are 3 types of epithelial cells that may be found in the urine, and these are squamous cells, transitional or urothelial cells, and the renal tubular cells. So squamous epithelial cells are the largest epithelial cells present in the urine. They have abundant irregular cytoplasm. They can have a prominent nucleus about the size of a red blood cell. So usually a few can be present in the sediment, and this can actually serve as a good point of reference for the focusing of the microscope. So these squamous epithelial cells are reported as rare, few, moderate, or many in low or high power field. So here are some clumps of squamous epithelial cells with folded forms and a special stained squamous epithelial cell. So the clinical implication of the presence of these squamous epithelial cells would be that they are indicators of contamination. The origin of the squamous epithelial cells are those of the linings of the vagina and the female urethra, as well as the lower portion of the male urethra. And normally they represent normal cellular sloughing and may have no pathologic significance. And some variation would be the presence of urcluses that are indicative of Gardnerella vaginalis infection. So transitional urothelial epithelial cells appear smaller than the squamous cells. They can exhibit as spherical or polyhedral in shape. They have distinct centrally located nuclei, and these are reported semi-quantitatively and using the terms rare, few, moderate, or many. So the transitional urothelial epithelial cells have the ability to absorb large amounts of water. So the urothelial epithelial cells also have the caudate forms as shown in this picture. So the clinical implication of the presence of transitional epithelial cells, likewise, they represent normal cellular sloughing and they can be present in small numbers. So they can be deemed normal when the identification of the transitional cells are seen following invasive urologic procedures such as catheterization. But presence of increased numbers of the abnormal morphology in the presence of vacuolization and irregularity in the nuclear borders can be indicative of malignancy or even a viral infection, and these may warrant cytologic examination. So the renal tubular epithelial cells can vary in the size and the shape depending on the area of renal tubules they originate from. So when they appear to be somewhat columnar with granules and attached fat globules, these are representative of renal tubular epithelial cells coming from the proximal convoluted tubules. So they are larger than the other RTE cells and they can be rectangular in shape or columnar or convoluted cells associated with granular cytoplasm. They can resemble casts, but absence of the nucleus is seen in the granular casts. When they appear ovoid, or with essentially placed nuclei, and they somewhat are smaller, round, or ovoid, these are renal tubular epithelial cells coming from the distal convoluted tubular cells. And they can be mistaken for WBCs or small spherical urothelial cells. And of course, the cuboidal cells or type of renal tubular epithelial cells that are arising from the collecting ducts. So they are cuboidal, they are never round, and they have an eccentrically placed nuclei with the presence of at least one straight edge. And these can be seen in groups or large sheets or the renal fragments. So here we see a renal fragment or a fragment of renal tubular epithelial cells under phase microscopy. So we know the function of the renal tubular epithelial cells to be reabsorption of the glomerular filtrate. So this can actually aid in the identification of renal tubular epithelial cells. So in cases of liver damage from viral hepatitis, there can be deep yellow granular structures or substances in the cytoplasm of the renal tubular epithelial cells that can represent bilirubin. Yellow-brown structures present in the cytoplasm of renal tubular epithelial cells in cases of hemoglobinuria in transfusion reactions or paroxysmal nocturnal hemoglobinuria can indicate the presence of hemoglobin or reabsorption of hemoglobin, and this can be confirmed by doing staining with Prussian blue stain where the iron-containing hemosiderin granules are stained blue. So for the clinical implication of identifying renal tubular epithelial cells on the urinary sediments would be that these may indicate tubular injury or renal tubular necrosis. So there are different conditions that can cause acute tubular necrosis, and these are exposure to heavy metals, drug-induced toxicity, hemoglobin and myoglobin toxicity, viral infections like hepatitis B, pyelonephritis, allergic reactions, salicylate poisoning, transplant rejection, or even malignancies. So the classification of the type of RTE is not usually part of routine sediment analysis, and more often than not would require the use of special stains. Reporting the presence of RTE cells on urinalysis are done semi-quantitatively, so using the terms rare, few, moderate, or many, or you can actually report the actual number per high power field. So the oval fat bodies, these are renal tubular epithelial cells that are containing or absorb lipids in the glomerular filtrate. So they appear highly refractile, where the nuclei of the renal tubular epithelial cells may be difficult to identify. So they are also called lipid-containing renal tubular epithelial cells. So oval fat bodies, they are seen in conjunction with free-floating fat droplets. Presence of these oval fat bodies can be confirmed by Sudan 3 or oil red O fat stains, and also with polarized microscopy. So these droplets represent the presence of triglycerides, neutral fats, and cholesterol. Now the fat stains would show orange-red droplets when these oval fat bodies are present, and the Maltese cross formation in the droplets identified using polarized microscopy indicate the presence of cholesterol. So identifying the oval fat bodies can imply lipiduria, which is associated with damage to the glomerulus caused by nephrotic syndrome. So this can be seen together with severe tubular necrosis, diabetes mellitus, and even trauma. So in trauma, there can be a release of bone marrow elements like bone marrow fat from the long bones. This can also be seen in lipid storage diseases where large fat-laden histiocytes can be identified. So bacteria in the urine should ideally be not present, or it can be only identified in trace amounts because of possible skin contamination. However, presence of large amounts of bacteria can be clinically significant, indicating active urinary tract infection anywhere along the urinary tract. That's usually in the bladder or termed as cystitis, or even in the kidneys or pyelonephritis. So the presence of bacteria can be reported when identified in fresh specimens and in conjunction with WBCs. The presence of yeast cells in budding forms aids in distinguishing them from the red blood cells. So they appear small, refractile, ovoid structures that may or may not be budding. So severe infections can also show branched or the mycelial forms, and presence of yeast cells are also reported semi-quantitatively, and most commonly the yeast cells present in the urine are of the Candida albicans species. True yeast infection in the urine should show budding yeast cells accompanied by leukocytes. So these are seen in diabetics clinically because of the acidic glucose-containing urine, which is an ideal medium for yeast cells to grow. Now, presence of yeast cells can also be just mere contaminants, especially when the urine is not examined fresh. So yeast cells can also be seen in immunocompromised patients and those with vaginal mondelliasis. Parasites can also be identified in the urine, and the most frequent one is the Trichomonas vaginalis, which are pear-shaped flagellates with an undulating membrane. They are easily identified in wet smears or wet preparation, and their common mimics would be the WBCs or transitional or renal tubular epithelial cells. But phase microscopy allows enhancement of the visualization of the flagella or the undulating membrane of the Trichomonas vaginalis. So it is sexually transmitted, associated with vaginal inflammation, and male urethra and prostatic infection can be deemed asymptomatic. So other parasites that may be identified in the urine are Schistosoma hematobium or the ova of the bladder parasite, or fecal contamination of the ova of pinworm or Enterobius vermicularis. Spermatozoa can also be identified in the urine. They appear oval in shape. They have slightly tapered heads with long flagella-like tails. Now, we know that urine is toxic to spermatozoa, hence rarely do they exhibit motility. So occasionally, the spermatozoa are identified following sexual intercourse, masturbation, or nocturnal emission. Now, they can be clinically significant in cases of male infertility or retrograde ejaculation. So this is when the sperm is expelled into the bladder instead of the urethra. So the protocols in reporting presence of spermatozoa in urine varies, so not reporting them may cite the lack of clinical significance or possible legal consequences. So mucus represent thread-like structures with low refractive index. They are protein material that are produced by glands and epithelial cells of the lower genitourinary tract and the renal tubular epithelial cells, and they are made up of the TAM horseful protein. So common mimics would be the hyaline casts, and they're reported semi-quantitatively, and clinical implications would be that they're often present in female urine specimens. Some generalities about urinary casts. So these are the only elements found in the urinary sediment that's unique to the kidney. So the casts provide a microscopic view of the conditions within the nephron. So they are formed within the lumina of the distal convoluted tubules and collecting ducts, and their shape are somewhat representative of the tubular lumen with parallel sides and somewhat rounded ends, and they may contain the elements present in the glomerular filtrate. So they ought to be examined along the edges of the cover slip on low power where they tend to aggregate into. And observation in subdued light should be done in bright field microscopy because of the low refractive index of the casts. So they may be dissolved in dilute alkaline urine, hence it's better that the urine is always examined in its fresh state, and they are also reported as an average number of 10 low power fields. So the TAMS horsefall protein, or also called the uromodulin, is the major constituent of the casts. So the TAM horsefall protein are glycoproteins excreted by the renal tubular epithelial cells of the distal convoluted tubules in the upper collecting ducts. So they may be present in normal and abnormal conditions, and usually these are not detected by reagent strip for proteins. So when the reagent strip for proteins are positive, usually they may be because of other proteins present in the urinary filtrates in the form of albumin or even other immunoglobulins that may also be incorporated into the cast matrix. So the rate of excretion can increase under conditions of stress and strenuous exercise. So hyaline casts are the most frequently seen casts in the urinary sediment, which consists almost entirely of TAM horsefall protein. So they are formed in the absence of cells in the renal tubular lumen. They have a smooth texture and a very low refractory index similar to that of the surrounding fluid. So they have a barely visible outline and they can blend into the background. Hence, increasing the background contrast would enhance its visibility. So when they are present in low numbers in concentrated urine of otherwise normal patients, these hyaline casts are not always indicative of a clinically significant disease. However, greater numbers of hyaline casts may be associated with proteinuria of renal or extrarenal origin. Hyaline casts can have normal parallel sides. So here we see a hyaline cast under face microscopy where the hyaline casts would exhibit rounded ends in a cylindroid form. Now, hyaline casts can also have wrinkled or convoluted shapes and can exhibit occasional adherence of a cell or a granule. So we see here a hyaline cast under low power with amorphous granules and mucus in the background. This slide shows different photomicrographs of hyaline casts. So you have the hyaline cast in its convoluted form. You have hyaline cast in association with amorphous urates and attachment to a mucus pseudocast, and also a hyaline cast containing occasional granules. Cellular casts are a result of disease processes such as ischemia, infarction, or nephrotoxicity, and they can cause degeneration and necrosis of tubular epithelial cells. So there are certain common clinical scenarios into which cellular casts are formed, such as decrease in renal perfusion and oliguria secondary to severe dehydration, ischemic injury where the sloughing off of epithelial cells would occur, restoration of urine flow following fluid therapy where numerous casts are flushed out of the tubules, and also leukocytes can be incorporated into the cast in cases of tubulointerstitial inflammation. RBC finding in the urine can be indicative of bleeding from an area within or along the genitourinary tract. RBC casts, however, are indicative and more specific for bleeding within the nephron and signifying glomerular damage as it allows passage of cells through the glomerular basement membrane, damaging the nephron capillary structure. This is seen together with proteinuria and the presence of dysmorphic erythrocytes. Now, RBC casts are detected under low power with orange-red color. It's highly improbable that RBC casts will be present in the absence of freestanding red cells and a positive reagent strip for blood. So here we see a COVA-stained RBC cast under phase microscopy and an RBC cast containing hemoglobin pigment, and a comparison of the red cells and yeast cells can also be made here. So we see a red blood cell cast here. So notice the presence of hypochromic and dysmorphic free red cells in the periphery. Now we see here a red blood cell cast and a disintegrating one, and notice the presence of the free red cells to confirm the identification of the RBC cast. So as an RBC cast ages, the cell lysis begins and the cast develops a more homogeneous appearance, but typically retains the characteristic orange-red color from the released hemoglobin. So WBC casts are primary markers for distinguishing upper urinary tract infection from lower urinary tract infection. So they're present in pyelonephritis and other non-bacterial inflammations such as acute interstitial nephritis, and can accompany red cell casts in glomerulonephritis. So they are visible under low power but must be identified positively on high power. They are composed of neutrophils which have granular cytoplasm and multilobated nuclei. So it's important that these WBC casts are distinguished from renal tubular epithelial cells, and identification of the free WBCs as well as bacteria can aid in discerning whether these are indeed WBC casts. So the cast can be tightly packed with white blood cells, and they can have irregular borders. So the structure should be carefully examined to determine that indeed a cast matrix is present. So WBCs frequently form clumps, and these do not have the same significance as cast. So you see in the upper left corner is a WBC clump, which is differentiated from a disintegrating WBC cast here and a COVA-stained WBC cast in the bottom photo. Bacterial casts are containing bacilli both within and bound to the protein matrix. And bacterial casts are often seen in cases of acute pyelonephritis, where you can have pure bacterial cast or admixed with the WBCs. So a common mimic of bacterial casts are the granular casts, and we can confirm their presence using gram staining on dried or cytocentrifuged urinary sediment. So epithelial cell casts or renal tubular epithelial cell casts indicate advanced tubular destruction. They produce urinary stasis with disruption of the tubular linings and are associated with heavy metal and chemical or drug-induced toxicity, viral infections, and allograft rejection. So the epithelial cell cast can accompany the presence of WBC casts in cases of pyelonephritis. However, the WBC cast is a common mimic of the epithelial cell cast. Hence, use of supravital staining and phase microscopy can be done to enhance the nuclear detail and pretty much assist in distinguishing the two. Fatty casts are seen in conjunction with oval fat bodies and free fat droplets. They are seen in the disorders causing lipiduria like diabetes mellitus, crush injuries, nephrotic syndrome, and toxic tubular necrosis. They appear to be highly refractile under bright field microscope. So the cast matrix can contain few or many fat droplets. They can have intact oval fat bodies attached to the matrix. So polarized microscopy and fat stains like Sudanthi or OIO can be done to document the presence of fatty casts. So the cholesterol tends to exhibit the Maltese cross formation under polarized microscopy. Triglyceride and neutral fats, they stain orange red with fat stains. However, the fats do not stain with the Sternheimer-Malbin stain. Granular casts may be pathologic or non-pathologic. They can be coarsely and finely granular. However, it's not necessary to distinguish between the two. So the origin of the granules in non-pathologic conditions are from the lysosomes excreted by the renal tubular epithelial cells during normal metabolism. Increased cellular metabolism during periods of strenuous exercise can account for the transient increase in the granular casts and hyaline casts. So the granules may represent disintegration of the cellular casts, the tubule cells, and protein aggregates filtered by the glomerulus. So some of the mimics of granular casts are clumps of crystals and even fecal debris. When granular casts remain in the tubules for extended periods, the granules further disintegrate and the cast matrix develops a waxy appearance, hence development of your waxy casts. So the structure becomes more rigid and the ends of the cast may appear somewhat jagged or broken down, and the diameter becomes broader. So it has a smoother consistency and becomes more refractile, and they have squared off ends. So the waxy casts are seen in chronic renal diseases, diabetic nephropathy, malignant hypertension, and glomerulonephritis. And with supravital stains, the waxy casts tend to stain a homogeneous dark pink appearance. So we see here some of the waxy casts with somewhat straighter edges and that are more prominent, some jagged appearance of the periphery, and the more fragile appearing waxy casts, and also granular casts present in this picture. So broad casts, also known as renal failure casts, represent extreme urine stasis. So when flow of urine to the larger collecting ducts becomes severely compromised, casts form in this area and appear broadened. So these are indicative of destruction of the widening of the tubular walls. So all types of casts can occur in a broad form, but given that these are associated with urine stasis, most are in the form of granular and waxy casts. A few general concepts regarding urinary crystals. So they are rarely of clinical significance, but there are few abnormal types that may represent disorders such as liver disease, inborn errors of metabolism, or renal damage. So urinary crystals can be reported semi-quantitatively per low power field. And they are formed by precipitation of urine solutes composed of inorganic salts, organic compounds, and medications. There are various factors that affect the formation of urinary crystals, such as temperature. Though temperature allows them to more readily precipitate, the solute concentration is another factor, where increase in the urinary solute concentration allows enhancement of the crystal formation. Now, pH can also determine the type of chemicals that precipitate. The organic and iatrogenic compounds tend to crystallize in an acidic pH, while the inorganic salts are less soluble in neutral and alkaline solutions. So one exception is the calcium oxalate crystal, which tends to precipitate in both acidic and neutral urine. Shown in this slide are the different normal crystals identified in acidic urine. Amorphous urates are one of the crystals that are seen in acidic urine. They appear yellow-brown granules occurring in clumps and often encountered in refrigerated urine specimens. Uric acid crystals exhibit a variety of shapes, either rhombic, four-sided flat plates, wedges, or rosettes. They can be yellow-brown or colorless with six-sided shapes. They are highly birefringent under polarized microscopy and associated with increased levels of purines and nucleic acids in leukemia patients under chemotherapy and patients with gout. Calcium oxalate crystals are commonly found in acidic urine, but can also be found in neutral or even rarely in alkaline urine. So the dihydrate forms are the most common ones. They appear colorless, octahedral envelope in shape, or as two pyramids joined at the bases. So clinically are associated with formation of renal calculi or intake of foods high in oxalic acid like tomatoes, asparagus, and ascorbic acid. So the oxalic acid is an end product of ascorbic acid metabolism. The monohydrate form of calcium oxalate crystals are less characteristic and less frequent. They are ovoid or dumbbell-shaped, and they are birefringent under polarized light. It's important to distinguish them from the non-polarizing red blood cells. They may be seen attached to mucous strands and resemble casts. The primary pathologic significance of calcium oxalate crystals in the monohydrate form is that they are increased in the cases of ethylene glycol or antifreeze poisoning. Listed in this slide are the different normal crystals that are found in alkaline urine. Amorphous phosphates also appear granular in appearance, similar to the amorphous urates, and they are commonly seen in alkalinized urine. They are present in large quantities following specimen refrigeration, and they can form a white precipitate that does not dissolve upon warming. Triple phosphate crystals exhibit the coffin lid or prism-shaped appearance. They are highly birefringent under polarized light, and they are formed in highly alkalinized urine associated with the presence of urea-splitting bacteria. The ammonium biurate crystals are also seen or identified in alkalinized urine. They exhibit a yellow-brown, thorny apple, spicule-covered spheric appearance. They tend to dissolve at 60 degrees Celsius and convert them to uric acid crystals when glacial acetic acid is added. So it's almost always encountered in old specimens, and also they're indicative of the presence of ammonia produced by urea-splitting bacteria. Abnormal urine crystals are found often in acidic urine. They have characteristic shapes, and identifying them should be confirmed by a chemical test or patient history like intake of specific medication. So some example of urine crystals are cystine crystals, cholesterol crystals, and even radiographic dye crystals. Cystine crystals appear colorless, hexagonal plates which may be thick or thin. They can mimic uric acid crystals, which are birefringent under polarized light. So the presence of cystine crystals are often seen in persons who inherit a metabolic disorder that prevents them from reabsorbing cystine in the renal tubules and hence causing cystinuria. So patients with cystinuria tend to be early kidney stone formers. So to be able to confirm the presence of cystine crystals, a cyanide nitroprusside test may be done. Cholesterol crystals are rarely seen unless the specimens have been refrigerated. Since lipids tend to remain in droplet forms, the cholesterol crystals tend to be very rare. So the most characteristic appearance of the cholesterol crystals are rectangular plates with somewhat notched in one or more corners, and they are associated with disorders producing lipiduria, and these are nephrotic syndrome. And they are seen often in association with fatty casts and oval fat bodies. So cholesterol crystals are highly birefringent under polarized light. Some urine crystals are associated with liver disorders. So in the presence of these severe liver disorders, 3 are rarely seen crystals that may be found in the urine sediment. And these should be seen in association with positive chemical tests that are often seen together with the others. So tyrosine crystals appear as the fine, colorless to yellow needles that form clumps or rosettes and are seen in inherited disorders of amino acid metabolism. Now, leucine crystals, these are yellow-brown spheres that demonstrate concentric circles and radial striations. And the bilirubin crystals are clumped needles or granules with the characteristic yellow-brown color of the bilirubin, often seen in hepatic disorders. Sulfonamide crystals or sulfa crystals are seen together with WBCs and bacteria in cases of urinary tract infections. So they're often seen in patients being treated for UTIs with inadequate hydration, which is the primary cause of the formation of sulfonamide crystallization. So the possibility of tubular damage upon crystal formation in the nephron is a consideration when sulfonamide crystals are identified. So the shapes commonly encountered are needle-shaped, rhombic or whetstone sheaves of wheat, rosettes with colors ranging from colorless to yellow-brown. Ampicillin crystals are not frequently encountered except for massive doses of penicillin compound intake without adequate hydration. So they also appear colorless needles that tend to form bundles following refrigeration. So note that the marked formation of the ampicillin crystals after refrigeration.